Good morning, colleagues. Good morning, everyone. We're so happy that you can join us this morning on this very important topic, another one of the PANCAPS webinar. I am Dr. Shalon Bovell. I am the project manager for the Office of the Principal Recipient, the Global Fund Project, and I am your moderator for today's webinar, which is titled Management of Advanced HIV Disease, an update on the screening, diagnosis, and treatment of fungal infections, histoplasmosis, cryptococcus infections. This is, as stated, another PANCAP webinar in collaboration with the Pan American Health Organization. And I wish to thank PAHO for the continued support and ongoing collaboration in advancing our continued medical education and building capacity for our healthcare providers, civil society partners in the region. Just a few housekeeping reminders. Your mics are all muted, so you are in listen-only mode. If you have any questions, please type and submit those questions. As the moderator, I will be able to see those questions and I'll be able to advance them as part of the discussion. Please feel free to type your questions in the chat bar as part of the webinar panel. These will be addressed during the questions and answer segment after the presentation by Dr. Edwards. We are recording the webinar, and therefore the recording will be shared on the PANCAP social media platforms for the benefit of persons who could not have attended this live session this morning. By continuing to be in the meeting, you are consented to be recorded. All right. At the end of the session, you will receive a certificate of participation, and we will email the presentation to you so you can peruse at your own during your own time at your own pleasure. Please allow me to introduce our facilitator of this webinar this morning, the speaker, Dr. Jeffrey Edwards. Dr. Edwards is a graduate in medicine of the Faculty of Medical Sciences, the University of the West Indies, and is the holder of a postgraduate diploma in urinary medicine from the University of Liverpool. Genitourinary medicine from the University of Liverpool. He has a Master's of Science in Dermatology from the University of Wales, Cardiff, and a Doctorate of Public Health from the University of the West Indies. He is the Director Consultant of the Medical Reference Foundation, Trinidad and Tobago. And this is one of the largest HIV clinic coordination of Masters of Public Health programs at the University of the West Indies, St. Augustine campus. And he's also the president of the Caribbean Dermatology Association. We welcome you, Dr. Edwards, to this webinar. And I know your screen is up and you can feel free to begin. Management of advanced HIV disease. We're providing an update on screening, diagnosis, and the treatment of fungal infections. Go ahead, Dr. Edwards. Thank you kindly.
Okay, morning. Thank you for that kind introduction. So in terms of my presentation, I'll talk about the advanced HIV disease and the packages of services. We look at the diagnosis and management of disseminated histoplasmosis and diagnosis and management of cryptococcal meningitis. So what is advanced HIV disease? The World Health Organization defines advanced HIV disease as persons who have a CD4 count less than 200, or if you have World Health Organization stage 3 or stage 4 disease in adults and adolescents. All children who are less than 5 years of age are considered to have advanced HIV disease, including both individuals presenting to care who are naive to antiretroviral therapy and those returning to care after interrupted treatment. they have an increased risk of progression, of disease progression and mortality in these children. Now, CD4 cell count testing is no longer required, as usually we used to use it in the past as a criteria to start antiretroviral therapy. Well, we now treat all, we start antiretroviral therapy as soon as possible, usually within 7 days diagnosis. Okay, so even testing is no longer essential to find out CD4 counts less than 200. So people with advanced HIV disease are at high risk of death even after they started the antiretroviral therapy. And this risk of death increases with decreasing CD4 cell count. So, and a lot of people still come into care very late. So again, they come in with advanced HIV disease, and even though we start medication, they have an increased risk of poor outcomes. The most common causes of severe illnesses and death among persons living with HIV are tuberculosis, severe bacterial infections, of course, fungal infections, disseminated histoplasmosis, and cryptococcal meningitis. So to reduce morbidity and mortality in patients presenting with advanced HIV disease, the World Health Organization offers a package of services, of interventions, including screening, and I'll talk about each one of these, treatment and prophylaxis for major opportunistic infections, rapid antiretroviral therapy initiation, and this is defined as within 7 days from the day of diagnosis. So we try to treat as soon as possible, and intensified adherence and support interventions. So the AHD package intends to widen access to key medicines and diagnosis, and to manage the most common causes of illnesses and death. So despite the expanded access to antiretroviral therapy and the rollout of the WHO Treat All strategy, the proportion of patients presenting with advanced HIV disease still remains at approximately 20 to 30%. And 50% of persons with advanced HIV disease report prior engagement in care. So they were engaged in care and then they fall out of care for whatever reason. So antiretroviral therapy failure and insufficient retention of HIV care are major causes of advanced HIV disease. So what is this package of services that we offer? All right, so we look at screening and diagnosis. So again, at the entry point, we do a CD4 count. So in persons with TB, if you want to do screening, we tend to screen at any CD4 count. And then there's a 4-symptom screen. We ask patients if you had any fever, weight loss, night sweats, or cough, okay? So that we screen them with that. If we suspect that they may have TB, we can collect a sputum sample and do molecular testing, or you can test it for acid-fast bacilli, all right? The WHO also recommends, in addition to the 4-symptom screen, a chest X-ray, the C-reactive protein, all right, and the rapid molecular diagnosis for TB. There's the expert, which is a PCR test that detects TB. You get a result in about 2 hours and also tells you if the patient is resistant to rifampicin. In patients who have low CD4 counts, for example, if they are outpatient with a CD4 count less than 100, we tend to do a TB LAM. The LAM is the lipoarabinomannan, which is part of the mycobacterial wall, all right? And there's a urine test, and we can pick this up. It tends to be a little more accurate in patients with low CD4 count. If the patients are inpatient, we can do the TB LAM at CD4 count less than 200. If the patient is symptomatic, all right, or seriously unwell, we can do the TB LAM at any CD4 count. Again, the TB LAM would suggest the patient may be infected with TB and they can do further testing. In patients who have a CD4 count less than 100, what we tend to do is we tend to screen them with the cryptococcal antigen test, and I'll talk about that later on. Okay, and if the cryptococcal antigen test is positive, we give them preemptive antifungal therapy. We also give cotrimoxazole prophylaxis in patients with CD4 counts less than 350, or if they have clinical stage 3 or stage 4 disease. Some people give the cotrimoxazole prophylaxis if CD4 counts less than 200. Of course, if the patient has a positive MAN2 test or at high risk of TB, we give TB preventative therapy. And as I mentioned before, in patients with CD4 counts less than 100, we will do the serum cryptococcal antigen test, and if it's positive, we can give fluconazole preemptive therapy for these patients. Part of the HD package is the rapid initiation of HART. This is defined as starting antiretroviral therapy within 7 days from the day of HIV diagnosis. All right, we tend to defer HART if the patient has symptoms suggestive of TB or cryptococcal meningitis, because remember, meningitis occurs in the brain and the cranium. There's a small space, so there's an increased risk of the iris, which is the immune reconstitution inflammatory syndrome. So we usually defer HART for about 4 to 6 weeks. Start treating the infection first and then defer HART until that period. Now, persons with advanced HIV disease should be given priority for assessment and for initiation of antiretroviral therapy. We talk about intensified adherence, where we support interventions, and these include intensive enhanced adherence counseling. You can look to do home visits or give the patient phone calls, to make sure that they continue to take the medication. Or you can look at home-based care or palliative care as part of the intensified adherence support. So let's talk about what we come to talk about today, histoplasmosis and HIV. So the dimorphic fungus, Histoplasma capsulatum, is endemic in Latin America and the Caribbean, and causes disseminated histoplasmosis in persons living with HIV. It's acquired by inhalation, so some of the risks include if you work with surface soil or you clean chicken coops, which are contaminated with bird droppings, or if you disturb bird or bat droppings, you explore in caves. Sometimes caves may have bat droppings or bird droppings in it. Or if you're cleaning and remodeling or demolishing old buildings, you may come in contact with soil that may have bird or bat droppings. Histoplasmosis has been recognized as a high priority fungal pathogen by the WHO and tends to affect people with impaired immunity, including persons living with HIV, among whom the most frequent clinical presentation is disseminated histoplasmosis. So how does disseminated histoplasmosis present? It may present with fever, fatigue, weight loss, hepatosplenomegaly, increased size of the liver and spleen, bicytopenia, pancytopenia. If the respiratory system is involved, you may get chest pain, cough, and shortness of breath in 50%, or it may present with shock and multi-organ failure in 10%. It tends to occur in patients with low CD4 counts, usually CD4 counts less than 150. Histoplasmosis may present as isolated pulmonary disease, and this tends to occur in patients with CD4 counts greater than 300. You may get central nervous system, gastrointestinal, and skin manifestations of histoplasmosis. Trinidad and Tobago is one of the endemic regions for histoplasmosis, and we tend to see people with skin manifestations, and I'll show you all a few photos of the skin manifestations. If there are central nervous system manifestations of histoplasmosis, the patient may present with fever, headache, seizures, focal neurologic deficits, and altered mental status. If the gastrointestinal tract is involved, you may get fever, diarrhea, abdominal pain, and weight loss. So you can see some of these skin manifestations. So patients may present with these reddish brown papules with a bit of scaling on it. Okay, and we tend to do a biopsy, and when you do the biopsy and you use the appropriate stains, you can identify histoplasmosis. Again, you can see the reddish brown papules. And here you can see more reddish brown papules that actually become confluent, some of them deeper brown. You can see the scale in there. Again, we would diagnose with biopsy here. There are certain tests, and I'll talk about the tests we can do for disseminated histoplasmosis in a bit. So in terms of diagnosing and managing disseminated histoplasmosis among patients living with HIV, remember the symptoms that I described before were non-specific, and actually they may be indistinguishable from TB. And actually we have patients who have both TB and histoplasmosis, and this complicates diagnosis and treatment. The WHO has stated that histoplasmosis may be responsible for 5 to 15% of AIDS-related deaths every year in the region. As I indicated, Trinidad and Tobago and some areas in the Caribbean are endemic for histoplasmosis. So to improve survival among persons living with HIV with histoplasmosis, we need early and rapid diagnosis. So there's something called the urine histoplasma antigen test. And then once you diagnose histoplasmosis, you need prompt initiation of optimal antifungal treatment. So after being diagnosed with histoplasmosis, all right, if the patient is HIV infected, you need to link them to care as soon as possible. And again, they need to start antiretroviral therapy as soon as possible because histoplasmosis, like I said, tends to occur in patients with low CD4 counts. So the guideline development group recommends the detection of antigen assays to diagnose disseminated histoplasmosis among persons living with HIV. This recommendation is based on the high diagnostic accuracy of the histoplasma antigen tests among patients living with HIV. And remember, I told you this is a urine test. It's non-invasive, so it's easy to use in resource-limited settings. This recommendation is conditional since it's based on a low certainty of evidence. So again, we recommend urine histoplasma antigen testing if the patient is suspected to have disseminated histoplasmosis. We actually did a study last year where we looked at 200 patients, with CD4 counts less than 350, and we actually screened them. We did a urine histoplasma antigen test. We used an ELISA to get this. And we also screened them for Cryptococcus, where we did a serum cryptococcal antigen test. Again, here we use a lateral flow assay, a rapid test for Cryptococcus, and we also use the ELISA. All right, and it was quite easy to do. So I mean, if you have a rapid test for Cryptococcus, it's quite easy to do. We actually tried to do a rapid test for histoplasma, but it wasn't as accurate as we'd like. So there is one available, a rapid test for histoplasma, but again, it is available, but hasn't been commercially available as yet. All right. In the case of mucocutaneous infections or skin infections, central nervous system and pulmonary only localizations of histoplasmosis, you may require complementary tests such as the antibody test or culture. Culture takes a couple of weeks, to get going. That's why the antigen testing is so important. Or you may do biopsy, you could do histopathological analysis of different specimens, including tissue biopsy or body fluids. In terms of treatment of moderately severe or severe histoplasmosis, we tend to use antifungal therapy, and amphotericin B is a drug of choice, liposomal amphotericin B, which is less toxic than the deoxycholate amphotericin B. Just to mention that Trinidad and Tobago, and I suppose some Caribbean islands, I mean, we don't always have access to amphotericin B. So again, the PAHO and PANCAP are working with the Caribbean countries, to try and speed up access to amphotericin B, because histoplasmosis and cryptococcal meningitis are life-threatening diseases, and they are high causes of deaths among patients with HIV. So the preferred induction therapy is liposomal amphotericin B, 3 milligrams a kilogram, 2 weeks. All right. The alternative therapy is the deoxycholate amphotericin B, which is 0.7 to 1 milligrams a kilogram. And again, it should be administered for 2 weeks. These are IV treatments. So the patient has to be in hospital, and this medication is administered intravenously. And then after the induction therapy, there's a maintenance therapy, which is itraconazole, 200 milligrams twice a day for at least 12 months. All right. Now, amphotericin B is quite toxic, especially the deoxycholate amphotericin B. So that's why it's important for us to try to get the liposomal amphotericin B. You may get some infusion reactions, for example, nausea, vomiting, chills, rigors, all right, with the amphotericin B deoxycholate. So this tends to occur usually 15 minutes to 3 hours following initial, when you set up and you give it. And what we tend to do is pre-treat the patients with acetaminophen or corticosteroids about 30 minutes before infusion. Now, amphotericin B tends to be phototoxic. So what you need to do is use opaque paper, to cover the, if we give it IV, so you cover the whole IV line, the burette, everything, all right? Amphotericin B is also associated with renal toxicity and affects electrolytes, so hypokalemia, hypomagnesemia, hypocalcemia, and hypophosphatemia. So if you're treating a patient with amphotericin B, especially the deoxycholate, you require daily monitoring of the renal function, the serum, creatinine, and electrolytes. And it may require potassium and magnesium supplementation during therapy and hydration with normal saline. So amphotericin B, especially deoxycholate, is quite toxic. And that's why it's preferable for us to get the liposomal amphotericin B. As I said, there's difficulty getting both in the Caribbean, especially in Trinidad and Tobago. So for people with renal failure or at risk of renal injury, all right, you want to prevent and monitor the toxicity associated with amphotericin B. So in these cases, the duration of therapy can be shortened based on clinical assessment of how the patient responds to treatment. However, involvement of the central nervous system may require extending the induction therapy or increasing the dose of amphotericin B. For mild to moderate histoplasmosis, all right, what we can do is give oral therapy. So a loading dose of itraconazole, 200 milligrams, 3 times daily, all right, for 3 days. And this is followed by itraconazole, 200 milligrams, twice daily for 12 months. All right, and this recommendation can also be used to treat an HIV uninfected immunosuppressed individuals for disseminated histoplasmosis. In terms of maintenance therapy, all right, remember we recommended 12 months of maintenance therapy. Less than 12 months of therapy can be considered if the patient is clinically stable, the patient is receiving antiretroviral therapy and has a suppressed viral load, and the immune status has improved, meaning that the CD4 count is above 200 for greater than 3 to 6 months. Then you may consider giving less than 12 months of therapy, but this is a conditional recommendation with very low certainty of evidence. So you have to balance the risk of relapse, drug-drug interactions, and side effects, okay? So clinicians may opt for shorter courses, at least 6 months, all right, of maintenance therapy in these instances. But again, what is recommended is 12 months of therapy. In terms of antiretroviral therapy in patients with disseminated histoplasmosis, antiretroviral therapy should be initiated as soon as possible, all right? Because remember, these patients are high risk of death. So Among patients with disseminated histoplasmosis, for whom there is no central nervous system involvement, all right, we need to start antiretroviral therapy as soon as possible. This is a conditional recommendation with a very low certainty of evidence. The Guideline Development Committee considered that the risk of potential harm from antiretroviral therapy was minor. Immune reconstitution inflammatory syndrome, IRIS, appears to be uncommon among people with disseminated histoplasmosis following antiretroviral therapy initiation. So this recommendation only applies to people without central nervous system involvement. So remember, if they have central nervous system involvement, you don't want to get IRIS in the CNS, because remember, the central nervous system, the brain and stuff, is a closed area. So you don't want to get IRIS. So we tend to wait usually 4 to 6 weeks before we start antiretroviral therapy if there's involvement of the central nervous system. How do you manage persons who develop IRIS if they have disseminated histoplasmosis? Typically, IRIS occurs a median of 60 days after initiating antiretroviral therapy. And the features of histoplasmosis-associated IRIS are non-specific, and they actually resemble the disseminated histoplasmosis, with symptoms that include fever, weight loss, cough, diarrhea, abdominal pains. How do we manage the IRIS, which is the immune reconstitution inflammatory syndrome? You continue antiretroviral therapy. You ensure that the patient is receiving optimal antifungal therapy, because IRIS is as a result of an immune response. You may want to give a short course of oral steroid therapy, for example, prednisolone, all right, if you have life-threatening complications. Okay, so you may want to give prednisolone 1 to 2 milligrams per kilogram per day. This may be given for 1 to 2 weeks, and then you could taper it off over the next 2 weeks. So in terms of IRIS, continue antiretroviral therapy, ensure you have optimal antifungal therapy, and of course, think of giving a short course of oral steroids for persons with life-threatening complications. All right, so that's the end of histoplasmosis. We're going to finish off now with HIV and cryptococcal disease. So Cryptococcus neoformans is a fungus most frequently found in bird droppings, mainly pigeons and soil. It has also been found in the bark, leaves, plant debris, and wood of the eucalyptus trees. This has been recognized by the WHO as a critical priority fungal pathogen. And again, as I can underscore this, both disseminated histoplasmosis and cryptococcal meningitis are causes of mortality among our HIV patients. So we need to be able to diagnose these and treat the patients, or they will go ahead and die. All right. Cryptococcal meningitis is the most common form of meningitis in persons living with HIV. And this tends to occur at low CD4 counts, usually CD4 counts less than 100, especially among patients who are not on antiretroviral therapy, those failing antiretroviral therapy, and those who defaulted from care and are lost to follow. Actually, the first case of AIDS in the English-speaking Caribbean was diagnosed by Professor Bartholomew in 1993, and this was actually in a patient with cryptococcal meningitis, okay? First case in the English-speaking Caribbean. The World Health Organization guidelines recommend cryptococcal antigenemia screening. So what you do a blood test for cryptococcal antigen in patients with CD4 counts less than 100 who are not on antiretroviral therapy. And if the cryptococcal antigen test is positive, you go on and give proactive antifungal treatment, all right, fluconazole for these patients. You want to prevent invasive disease. So how do we diagnose cryptococcal meningitis? The gold standard for diagnosis of cryptococcal meningitis is culture of the cerebrospinal fluid, meaning you have to do a lumbar puncture and culture this. And this may take 1 to 2 weeks for a definitive diagnosis. It requires trained laboratory personnel. You have to have the facilities to do the lumbar puncture, all right? And this technique may not be available in many resource-limited countries. So cryptococcal antigen detection tests all right? Provide rapid and accurate methods for the diagnosis. So you do a blood test, all right? And there's a rapid test we can actually use. And you get back the results in about 20, to 30 minutes. And you can see if the patient has cryptococcal antigen positive. And what we tend to do, especially, we tend to refer that patient to hospital to see if they can get a lumbar puncture to make sure they don't have cryptococcal meningitis. So a systematic review and meta-analysis of the serum cryptococcal antigen screening and cryptococcal meningitis reported a sensitivity of 99.7%, a specificity of 94.1%, and using these, you can actually quantify the incidence of cryptococcosis in persons living with HIV. All right, let me just show you the test quick and I'll come back to it. And this is the test, okay? 2 lines positive, 1 line negative, all right? So again, you can get a result usually in 20 to 30 minutes, quite quick. Cryptococcus is a serious life-threatening disease. So again, we need to treat them. So in terms of diagnosing and preventing and managing the cryptococcal disease, early diagnosis and treatment is key to reducing mortality from cryptococcal disease. I've seen lots of patients die from cryptococcal meningitis because, as I say, a lot of times we don't have amphotericin B available, and we try to treat them with fluconazole, which is not great, all right? So it has a high mortality. So again, early diagnosis and treatment is key to reducing mortality from cryptococcal disease. So healthcare workers should have a low threshold for suspecting cryptococcal meningitis in persons with advanced HIV disease. A national program should give priority to reliable access to rapid diagnostic cryptococcal antigen assays, preferably the lateral flow assays, which is the rapid test, for use in serum, plasma, whole blood, or cerebrospinal fluid. So in Trinidad, although it's intermittent, we do have access to the cryptococcal antigen test, and we can get a result. Again, we can do the serum and also the CSF if we do a lumbar puncture, and they get the results pretty quickly. All right, so we could immediately start treatment. So physicians should maintain a high index of clinical suspicion for the diagnosis of cryptococcal meningitis, especially in patients who have a CD4 count less than 100, all right? Cryptococcal meningitis, unlike bacterial meningitis, tend to have a more indolent presentation, all right? Most patients with cryptococcal meningitis tend to develop these early non-specific symptoms. They may get a fever, headache, and usually most of them don't have the classical signs of meningeal irritation, that neck stiffness. So initially, early on, you may have fever and headache, generally little or no neck stiffness. So you should have a high index of suspicion here, all right? And try to do the lumbar puncture as soon as possible. However, as the disease progresses, then the patients develop altered mental status, the neck stiffness, or cranial nerve abnormalities. Approximately 10% of patients with disseminated cryptococcal disease will have skin manifestations, which will resemble the lesions of molluscum contagiosum. I'll show you this in a picture next. Patients may also develop pulmonary cryptococcal disease with or without central nervous system involvement. So they can develop lung disease also. And this is the cryptococcal meningitis here. You can see, not meningitis, the skin manifestations. You can see these skin-colored papules with central umbilication, the white stuff in the middle here, that looks like molluscum contagiosum. Again, you biopsy it, stain, and they show cryptococcus. So this is skin manifestations of cryptococcosis. Looking at the presenting signs and symptoms of cryptococcal meningitis, you can see most common is fever, headache, and you can see the stiff neck is only in 37%. So you should really have a high index of suspicion, all right? And go on to see if you can do the lumbar puncture to make the diagnosis, all right? You got a change in mental status and the central nervous system deficit. So how do we diagnose cryptococcal disease among persons living with HIV? So for adults, adolescents, and children living with HIV, if you suspect they're having a first episode of cryptococcal meningitis, you can do a CT of the brain, probably some with contrast, because you want to exclude any mass lesions that may result in herniation. If you don't have a CT scan, you can look in the eyes for signs of papilledema, all right? Once you don't see any signs, any mass lesions that could cause raised intracranial pressure, what you can do is you can go on to do the lumbar puncture, and you measure the CSF opening pressure. This tends to be high in patients with cryptococcal meningitis. Again, in Trinidad and Tobago and probably the rest of the Caribbean, the facilities for measuring the CSF opening pressure is generally not available. Once you get the CSF, you can do a rapid cryptococcal antigen test on the CSF, all right? And this is the preferred diagnostic approach. There's a strong recommendation with moderate to certainty evidence. If you don't have the cryptococcal antigen assay, you can do the India ink test, and I'll talk a little bit about this later on. So looking at patients with cryptococcal meningitis, usually between 190 to around 200 is a increased cryptococcal opening pressure, and you can see a lot of patients tend to have increased CSF opening pressure. That's if you can measure the opening pressure, okay? And this is a high cause of mortality too, so again, you need to reduce the raised intracranial pressure in patients with cryptococcal meningitis, and briefly mentioned this also. So in settings with access to no contraindications to lumbar puncture, all right, so one, if you have both access to the cryptococcal antigen assay, you can either have the rapid test or an ELISA, all right, and you can get the results within 24 hours. You should go ahead and do the lumbar puncture and then do the rapid CSF cryptococcal antigen assay. This is the preferred diagnostic approach. All right, so strong recommendation, moderate certainty of evidence. So lumbar puncture and rapid cryptococcal antigen tests give you a result within 25 to 30 minutes. Now, two, if access to the cryptococcal antigen assay is not available, or you're not able, if you might have an ELISA, but you're not able to get the results within 24 hours, then what you can do the lumbar puncture, and then you can examine the CSF with India ink, all right? This also has a strong recommendation with moderate certainty of evidence. In 1983, when Professor Bartholomew diagnosed the first case of AIDS, the patient, as I told you, had cryptococcal meningitis, and he had to use the CSF India ink test to diagnose it. Again, I showed you this before, the rapid test, 2 lines positive, 1 line negative. Again, you get this in 20 to 30 minutes. Or you can do an India ink test, all right? And with the India ink test, you get a budding yeast with a thick polysaccharide capsule and a clear halo around it, that halo around it, all right? And this tells you the patient has India ink. You can see it here. Again, a budding yeast with a thick polysaccharide capsule, and see the halo around it. So you can know the patient has cryptococcal meningitis, and you can go ahead and start treatment, all right, as soon as possible. Now, looking at settings that don't have immediate access to lumbar puncture, or if the lumbar puncture is clinically contraindicated, all right, we look at a couple of scenarios. If you have access to the cryptococcal antigen assay and rapid results, you can get the results within 24 hours. What they recommend is you can do a serum, plasma, whole blood cryptococcal antigen assay, all right? So lumbar puncture, not available or contraindicated. You can do serum, you can do the blood, all right? And you can do the serum cryptococcal antigen assay here, all right? And again, you get a result in 20 to 30 minutes. And it'll tell you if the patient has cryptococcosis. Or two, if the cryptococcal antigen is not available and rapid access to results is not ensured, then you need to refer this patient, all right, for further investigation, because they can't do the lumbar puncture and they're not able to do the cryptococcal antigen test on the blood because they don't have it. All right, this is a strong recommendation. So you need to refer this patient for further investigation and treatment. In terms of preventing and screening for cryptococcal disease among persons living with HIV, all right, what we tend to do is we screen, especially if the patient has a CD4 count less than 100, you can screen the plasma, serum, or whole blood cryptococcal antigen, all right? And if this is positive, you follow up this with preemptive antifungal therapy, all right? This is fluconazole therapy. And what you want to do here is you want to prevent the development of invasive cryptococcal disease. What we tend to do is if the cryptococcal antigen test is positive, we tend to refer the patients to hospital and try to convince the physicians there to try and do a lumbar puncture because, again, we really have to do lots of convincing because, again, these patients are fairly well and physicians wonder why you want to do a lumbar puncture in them. So, I mean, we try to convince them and we get them done in some cases, but not in all cases. All right, so cryptococcal antigen testing followed by preemptive antifungal testing, all right, is recommended before initiating or reinitiating HART, all right, in adults with CD4 counts less than 100. So what you do is you start treating the cryptococcal disease before you initiate antiretroviral therapy, all right, especially in CD4 counts less than 100. With CD4 counts less than 200, you may also want to consider this cryptococcal antigen screening using serum, plasma, whole blood. All right, and we also want to consider preemptive antifungal therapy, but this is a conditional recommendation with moderate certainty of evidence. So all patients with a positive cryptococcal antigen screening, they should be carefully evaluated for signs and symptoms of meningitis. So as I said, we usually refer the patient to hospital, all right, and undergo a lumbar puncture if feasible with CSF examination for the cryptococcal antigen. If you don't have the cryptococcal antigen, you can do the India ink test, all right? But the India ink has a low sensitivity and a negative result should be confirmed by a CSF cryptococcal antigen test or CSF culture. Again, as I mentioned, you have to convince the physicians on the ward that the patients need this lumbar puncture. If cryptococcal antigen screening is not available, all right, and the patient has a CD4 count less than 100, then the WHO recommends fluconazole primary prophylaxis should be given to these patients, all right? This is a strong recommendation, moderate certainty of evidence. So in patients with CD4 counts less than 100, if you don't have access to the cryptococcal antigen test, then the WHO recommends you can give fluconazole primary prophylaxis to prevent the patients from developing invasive cryptococcal disease. And this may actually be even considered in patients with a higher CD4 count less than 200. But again, here, the recommendation is conditional with a moderate certainty of evidence. So in terms of treatment of cryptococcal meningitis, the following is a preferred induction therapy. So you give a single high dose of liposomal amphotericin B, one single high dose, 10 milligrams a kilogram, all right? And then you give 14 days of flucytosine orally in 4 divided doses. Again, I have to admit that in Trinidad and Tobago and probably the rest of the Caribbean, we don't really get access to flucytosine. Don't think I've actually seen a patient being treated with flucytosine. But again, it's strongly recommended. And so a single dose of liposomal amphotericin B, 10 milligrams a kilogram, flucytosine, 100 milligrams a kilogram per day in 4 divided doses, and then fluconazole, 1200 milligrams, all right, for 2 weeks. Of course, we don't have amphotericin B, either the deoxycholate or the liposomal. So in terms of alternative induction therapy, if you don't have the liposomal amphotericin B, you can give a 7-day course of amphotericin B deoxycholate plus flucytosine, all right? This is then for 7 days, and this is followed by 7 days of fluconazole, which is a strong recommendation, moderate certainty of evidence. or another alternative induction regimen. We can give 14 days of liposomal amphotericin B. Usually, as I say, if you have flucytosine available, fine. Or 14 days of liposomal amphotericin B plus fluconazole, 1200 milligrams daily. And the induction therapy is usually for 2 weeks, 14 days. Another alternative regimen, 14 days of amphotericin B deoxycholate plus fluconazole, 1200 milligrams again. And then another alternative therapy is 14 days of fluconazole, 1200 milligrams a day, plus flucytosine divided in 4 doses. So you have a number of alternative regimens, but the preferred regimen is a single high dose of liposomal amphotericin. I mentioned to you, generally, liposomal amphotericin is really difficult to come by. You may get intermittently. Deoxycholate amphotericin B is difficult, so we generally may have to do these 14 days of fluconazole, 1200 milligrams, all right? We don't have access generally to flucytosine. So for the most effective regimen to treat cryptococcal meningitis, all 3 drugs are available, should be available. Amphotericin B, liposomal is less toxic. Flucytosine that I mentioned that we rarely have access to, and the fluconazole. Again, same thing with toxicity of amphotericin B. You get infusion reactions. It affects the electrolytes and the renal function. So you may need to monitor the creatinine and electrolytes. And you may require supplementation of potassium and magnesium. In terms of, so after 2 weeks of induction therapy, you need to do a consolidation regimen, which is 8 weeks of fluconazole, 800 milligrams daily, all right, for adults. Again, so 2 weeks consolidation, usually amphotericin B plus fluconazole plus flucytosine, and then 8 weeks of consolidation therapy, 8 weeks of fluconazole, 800 milligrams daily. And then after the 8 weeks, you have a maintenance regimen of fluconazole, 200 milligrams daily. And they tend to give this for, again, at least 6 months, all right? Or some people give it until the patient has immune reconstitution. The CD4 count is greater than 200 milligram, 200, all right, for more than 3 to 6 months, and the patient's viral load are suppressed on antiretroviral therapy. Now, with cryptococcal meningitis, timing of ART is important. Patients with cryptococcal meningitis, ART should be deferred for 4 to 6 weeks, all right, from the induction of antifungal therapy, because patients could get a severe iris, which has been known to result in the demise of the patient. So ART initiation is not recommended immediately, all right? You treat the cryptococcal meningitis with the antifungal therapy for about 4 to 6 weeks, and then later on initiate ART, because you can get this iris, which can be severe and result in the death of the patient. Again, remember I told you raised intracranial pressure, they may have high open pressure. You need to monitor patients for raised intracranial pressure, all right? So you can do this with the initial LP, and then you can repeat the lumbar puncture. If you have facilities, you can measure the lumbar puncture at each, the CSF opening pressure at each lumbar puncture, looking for signs of raised intracranial pressure. How do we manage elevated intracranial pressure? You can do daily lumbar punctures, which again, you have to go sticking everybody. And if you're not proficient at it, patients don't really like you to do lumbar punctures. So again, what you can do is, if you do a lumbar puncture, you can put in a lumbar drain so they can remove the 20 to 30 cc's every day. Or you can do one of these surgery, the ventriculoperitoneal peritoneal shunts, all right? There's no role for steroids or acetazolamide in management of increased intracranial pressure in patients with cryptococcal meningitis. You need to remove some of the CSF, okay? Either by lumbar drains, daily lumbar puncture, or these ventriculoperitoneal shunts. So in terms of treating patients, if the patient has a relapse, for persons who present with cryptococcal meningitis following relapse, You need to start or restart induction therapy, like we mentioned before, the 2-week induction therapy. You need to manage the raised intracranial pressure with the therapeutic lumbar punctures or the drains, lumbar drains, or the ventriculoperitoneal shunts. Reinforce adherence to treatment. And if antiretroviral therapy has not been started, you need to initiate antiretroviral therapy. Again, remember, 4 to 6 weeks there because you can get a severe iris. All right, so those are my references. If there are any questions, I'll be happy to take them. Thank you.
Thank you
So over to the
kindly.
moderator.
Yes, thank you so much, Dr. Edwards, for the very comprehensive outline of advanced HIV disease, the details presented in terms of really capturing the advanced HIV disease package, looking at screening and diagnosis and emphasizing the importance of early diagnosis and treatment, rapid art initiation, even as we intensify adherence support, etc. Of course, the details related to HIV and disseminated histoplasmosis, uh, presentation and treatment, HIV and cryptococcus meningitis. Thank you so much. I know this really brings about some of the clinical um, analogies in terms of managing, treating these two critical conditions, which can be fatal in patients and must be prioritized in terms of important in management. Colleagues, based on our very in-depth presentation, we now yield to questions from our attendees, our participants, and we've had an overwhelming support in terms of this webinar this morning. Please provide all questions in the chat. I am not seeing any at the moment, but please do, if you have a question, any clarifications, etc., please do type them in the chat, and Dr. Edwards will be able to facilitate in terms of answering. All right, so thank you so much for the detailed presentation, the comprehensive outline, Dr. Edwards, of advanced HIV disease. And even as we manage the support and the response, the regional response to HIV in the region, this should be considered in terms of prevention, care, treatment, and support, the whole continuum of care, treatment, support that is provided, even from the regional standpoint, as we address this very important consideration as our regional response becomes more expansive. Any
Yes, thanks. Again,
questions?
just to throw out a few little things here. The access to amphotericin B, especially liposomal amphotericin B, the access to flucytosine, we need to work in the region to try to get these things available so we can treat these fungal infections that high causes of mortality. So it's very important there.
Definitely, Dr. Edwards, in terms of high mortality, uh, morbidity, etc., in terms of these conditions. So definitely, I really want to reiterate your call for early diagnosis and treatment, screening as our patients present, and then based on the outline, whether it's disseminated histoplasmosis or cryptococcus meningitis, really even the call for linkage to care as we provide early ART initiation. So thank you again. I do not see any questions. Dr. Edwards, at this time, do you have any final closing remarks? I believe the presentation
Okay,
was
so
very
just
clear.
in terms of closing remarks, as I mentioned before, we should work together as a Caribbean region, PAHU, using probably the PAHO revolving fund to get access to liposomal amphotericin B. We really need it, to get access
Okay.
to flu cytosine. We really need it, and to get access
Right.
to the antigen testing also. So the cryptococcal antigen testing and the urine histoplasma antigen testing. Well, if we get access to these things in the region, then we can diagnose and treat these conditions very well. In Trinidad and Tobago, we got access to because we actually did a study. So it's part of the study. We got the ELISA machine, all right, to be able to do the cryptococcal antigen and the histoplasma antigen. And we also got access to rapid tests for the cryptococcal antigen. But again, that's important. So access to the materials to diagnose, and then access to the appropriate medications to treat the conditions.
And that is resounding in terms of access, even as you present advanced HIV disease and the call for even greater collaboration with our partners from PAHO in terms of accessing the critical medications, liposomal amphotericin B, flucytosine, etc., and of course the investigative diagnostic screening mechanisms that are not present in all of our member states. And as we continue our strides towards bringing about a more comprehensive regional response, these are critical concerns that we can put forward and engage not only PAHO but also UNAIDS so that we can have greater access in the region. Given the fact that we are at 12, just after 12, I would like to again thank you, Dr. Jeffrey Edwards, our colleague and very technical support, very stellar technical support from Trinidad. For the presentation this morning. We will be able to share the presentation. Dr. Edwards will send the presentation to us and we will share it with the wider participants as part of the webinar. We thank you for your committed support to these webinars, colleagues. We thank you for your participation today. I also want to, on behalf of Dr. Singh and the PANCAP team, thank our back support from Richard Francois, etc., in terms of making all of this happen this morning. Please feel free to join us. We will publicize the next webinar, viral hepatitis, and this webinar will be aired, will be conducted in April. So this is our March webinar, and we continue to support you as we provide a very comprehensive, detailed presentation of HIV, HIV disease, HIV, and also critical supporting conditions that can advance your knowledge and your capacity as professions in the healthcare setting, as civil society support workers, etc. We thank you again, and we do look forward to your continued participation. Thank you, and thank you again, Dr. Edwards. Do have a good rest of the day.
Thank you.
Take care. Bye.